Okay, so fractures are easy. They're either open or closed, and we splint them. Bandage and splint them, take them to the hospital. Any questions? Okay, next chapter. You wished. I saw this over the break. It's a true statement all the time. So there's multiple different levels of stupid, and you see them all in EMS, or if you're going to work in the emergency department, you probably, well, in your clinicals you've already probably seen it, right? Seen a lot of stupid. Anybody see that one? Yeah. Yeah. I replayed it like 10 times on YouTube.
I had it recorded and they put in slow motion.
I couldn't hear the snap.
I know.
I just hear it.
Yeah.
I thought my dad was going to faint. He was standing up watching it. I really thought he was about to faint.
My whole house hoping like, let's do that again. What do you mean you're not going to show it? Show it again. So we got it on YouTube and was like, yeah, that's broken. The x-rays are sort of floating out there, but who knows if it's the real x-rays or not, right? But there's no doubt that that is fractured because that's called false motion. That foot can't go that direction. Okay? I don't care if you're like triple jointed or whatever. It's called false motion. It's fractured. It just can't go that direction. And if you watched it in slow-mo, you don't even have to be, you could be a lawyer and go, well, that thing's broken. Right? Okay? So, not a problem. Anyway, one thing before we go, and we'll bring this up a little bit later when we look at that, of course what I wanted to do was to, if I was there, I'd splint it in place, which a lot of fractures, you'd want to splint it in place, okay? You wouldn't necessarily take his foot and move it back to the normal place, right? Because you could do a lot of damage there. They did that because there was a surgeon, an orthopedic surgeon, that's there for these professional players, right? So the doctor did it, not the EMS personnel. The EMS personnel didn't put that foot back in place. That would have been reducing a fracture, is what it's called, and it's outside of your scope of practice. Me, personally, I thought it would be cool to splint that in place and drag him, cart him slowly off the thing with the field and watch everybody throw up as we go by, because he would have one foot down and one foot up like this. Thinking off the stretcher, I mean, like, that would be really cool to do. But EMS world, you might do that. I don't think I would reduce that because or try to manipulate that. The only time that you would reduce or move a fracture, you wouldn't necessarily splint it in place if it was logistically impossible to transport the patient, or if there was an absent pulse. If there wasn't getting any circulation there, then you would slightly manipulate that to try to regain circulation. Otherwise, you splint in place. Okay, and we've done some splinting already, so that's not a thing. We'll talk about that. We'll see some other fractures along the way, but that was, as far as the fracture is concerned, that was impressive. You don't have like a 300-pound fatty fall on your lower extremity like that, not fractured, right? And he's not one fatty. I mean, that dude was huge, muscle bound. Anyway, real quick through the anatomy part. If you don't know the anatomy by now, I can't help you, okay? Anyway, muscles, joints, ligaments, tendons. Some have more experience than others with those tendons and ligaments, right? The musculoskeletal gives us motion. It protects the internal organs. Produces red blood cells. You just sort of look down through there. Just make sure that you review the anatomy. Remember, we have voluntary muscles that help us move, walk. Involuntary, like the internal organs, respiratory organs, cardiac muscle, right? So everybody's already familiar with that. Should be familiar with this too. Tendons connect muscle to bone, and ligaments connect bone to bone. So the whole ACL thing, the L in that for ligament, okay, I'm not really sure. It's outside. Really, to know all those ligaments are not necessary for a pre-hospital provider because we make it easy. When in doubt, splint it. And if it's a ligament or a tendon that's damaged and it's not fractured, okay, so what? The treatment is still splint it. So you would splint it. Okay. What did you tear? Your meniscus?
Meniscus.
Yeah. So your knees all flopping around, we would splint that. We don't know if it's fractured until they do the x-ray, right? The MRI, whatever they're going to do. So we would splint it. We would treat it as a fracture. And I've been fooled a couple times thinking, man, that you know, he's just like that football player. It's a tib fib fracture, right? And then doped this guy all up, made him really happy, and he had essentially a twisted ankle, soft tissue to the ankle, but it looked fractured. All right. He wasn't in any pain, but when, anyhow, but we did the same thing. We splinted it. ALS wise, I was able to give him some pain medicine, but it ended up being soft tissue. I made my mother-in-law fell off the stairs and she had 2 injuries, compression injuries to her heels, and I didn't think she was, they were fractured, and I said, yeah, you're bearing weight. I don't really think they're fractured. Both of her lower legs were broken, had small fractures in them. So you just really know, you don't know until you shoot that x-ray, okay? Cartilage, we know what cartilage, you know, to the connective tissue, you can have damage to the cartilage as well, but no problem. We're just going to splint it. We have the easy part. So there's the tendon, connect the muscle to the bone, and then the ligaments connect bone to bone. Okay. Sort of inside, you can sort of see the different anatomy as far as the knee and the tibia are concerned here. I think that's what that is. But just be familiar with the anatomy. The motions that we do, flexion, like you're flexing, extension. I remember these. Adduction or abduction. Adduct means to take. That's the way I remembered them. So if I'm going to abduct your water bottle, I'm going to take it. Right? So I'm pulling it in. Abduction is just opposite. It's just the opposite way. Rotation, turning and rotating. A lot of these are just ways that we can occur fractures, okay, and muscle injuries as well. As you get older, you'll learn if you turn the wrong way, you can sort of tweak a muscle, and those things hang on forever. Okay, I've tweaked a muscle brushing my teeth before. I don't know how. I was sitting in there in the mirror brushing my teeth away, and I just turned the wrong way. I'm telling you, I couldn't hardly breathe for like 2 days. Every time I took a breath, I'm going, it's like someone kicked me in the ribs. I have no idea how I did it, but you just turn the wrong way. Lifting and moving, by the way, it doesn't take much when you turn here to pull something. All right. So when you like this book here, if I was to move this book, I wouldn't necessarily do this like that, even though this is fairly light, right? I would actually move here and set the book down, because this motion over here you can develop a back injury. As young as you guys are, probably not very bad, but an old guy, you want to make sure that you watch the way that you twist and lift. Thorax, the spinal column, skeleton, extremities, okay? all this should be very familiar to you with the bones. If needed, review over the anatomy, review over the bones, but I think everybody's pretty secure with the larger bones, okay? So when we look at a fracture, it's just a break in the bone somehow. It can be open and closed, it can be displaced, okay? Osteoporosis. There you go. It's just a degenerative bone disease, okay? Some people get it when they get old. Women have a lot of problems with it, okay? That's why you see the women all sort of, it's a different word, but they're all sort of turned over. Young people can have it. I know some young people that and they have a longer name that had a bone disease, and he had to be very careful. He could fracture a bone by slipping off of a curb, you know, or getting any kind of small trauma, okay? So when you look at fractures, strains, sprains, dislocations, they all have very similar signs and symptoms, okay? Like I said, when in doubt, splint it. So pain, tenderness, deformity, all right? You look at it and it's got deformity in it. The only way that you can be sure that it's fractured without an x-ray is if you have false motion, right? One foot going the wrong way, okay? Or you can see the bone, okay? Then you know it's fractured. Otherwise, you have to splint it and get it x-rayed. You're not really sure if it's fractured, okay? They feel this sort of pins and needles in it. You get inability to sort of move the extremity, and this would be bad. You decrease perfusion to the distal tissue of the fracture, from the fracture, okay? So these are some signs and symptoms. They're pretty common, you know. I mean, you don't have to really be, you know, Dr. Spock to say, okay, hey, this is a fracture. Everybody knows about broken bones, right? You can't get your age without that. There's different names for them. Ever how you say that? I haven't been able to say it in years. Committed. Yeah, there you go. It's all broken up in little pieces. Okay? See, an impact fracture, like if you were to jump off the school or something and land on your feet, not only could you have a...
Sorry, that makes me hurt. It hurts my knee to think about something like that.
Yeah, you jump. Well, you can probably have this fracture. You get thrown up in the air and nobody catches you and you come straight down, right? And land on your legs. You can sort of impact that fracture. See the lines here, how it's sort of splintered out? Okay? We won't know this. We will splint and transport, right? Because we're not really sure. A green stick fracture is an incomplete fracture. This is something that takes place in pediatrics because they're not all bone yet. There's still a lot of cartilage. It's green stick. It gets it from you get a tree limb that's still alive and you try to break it. It doesn't break. It just sort of tears and you have to sort of just pull it apart. Okay. So they're called a green stick fracture or a silver fork fracture. I think I have a picture because they looks like a fork, but it's an incomplete fracture. Oblique is a turning fracture or a spiral. Oblique is across the bone, and then transverse is a clean fracture. Okay? Depending on which type of fracture you have is the length of repair and the amount of repair, right? Pins and needles, right? Pins and screws, okay? Screw there, probably nothing, just set it back in place. Hard cast, right? Hard cast, not a big thing. It may need a screw in there, right? So put it all back together. So that's the only really big difference in the fractures is the amount of surgery or repair that they're going to have. Open and closed. Closed, just like a soft tissue injury, doesn't break the integrity of the skin. open, it breaks the integrity of the skin, okay?
Oh, that reminds me of the Cowboys game. Oh.
We
Yeah.
saw one of these, it seems like it was last year in the ED, where they put this person's ankle back in. Was it, anybody remember that? We were in there, we watched it. It was sort of, everybody went, you know, but they, so if we look here, closed fracture, okay, it's closed, but is it dislocated or fractured?
I mean, I would say dislocation.
Yeah, in the patient, I mean, it was almost the exact injury in the emergency department we were looking at. They had to set it back quick because her foot was smurfed.
Yeah.
Oh.
It looks like it.
Yeah, and so but it actually ended up, her foot, the real patient I'm talking about, her foot was just dislocated. They popped it back in. It looked fractured. Everybody was saying, oh yeah, it's broke, tib fib broke, but it was just dislocated.
Oh. Okay.
Fractured?
Yeah.
What
Is that a foot?
That's the side of the foot. Oh, boy. Wow.
Yeah.
Oh,
That's-
wait, is that the other side?
X-ray needed to determine if it's fractured?
No.
No, it's definitely an open fracture. Okay, it'll bring this up in just a minute, but I've seen this several times. The funniest one was this drunk was driving and the drunk was riding, but the riding drunk thought the truck was stopped and it wasn't stopped, and so he opened his door to get out, and they were going like 70 miles down the road. Okay, and the first drunk came to the door. They stopped at the EMS station for some reason, and says, "Hey, my buddy's hurt," and he's sort of leaning. His head's over towards the steering wheel. His foot's towards the right door. So I went out there and I opened the door, and boom! The only thing was holding his foot on was skin, and so I was like, "Yeah, that's fractured." But a pillow splint works real good. Just a normal bed pillow to sort of wrap around that and put on that type of fracture. This is the green stick fracture that we're talking about. I have a better picture, but I didn't add it, I don't think, because this one was on here. But this sort of incomplete green stick, see how it sort of, this end sort of looks like a fork? If you were to draw like little things that you stab with, you know what I'm talking about. Can you imagine that sort of looks like a spoon or fork? Okay.
Spoon, sure.
But green stick fracture, just incomplete, only in pediatrics, okay? That's,
Yeah. I remember when we had watched it with Buzz in middle school. You don't know where.
One leg, you would once respect, great. Get clout from someone's pain.
but yeah, definitely fractured, right? No x-ray needed, splint in place, open fracture, so we want to make sure we put a dry sterile dressing over that bone and over the open tissue, right? Splint, do the CMS checks, all that, do the splinting. We'll talk about that procedure when we get there in a few minutes, okay? But definitely open fracture. This is a special one.
Blowout fracture, great.
Yeah. The yeah.
I
Wait.
think he got ran over.
Be warned, this is a special fracture.
Yes, then I would look down.
Okay, but too late now, it's already out there, right?
That is.
Okay, this is called a blowout fracture, and it's blowout because everything was blown out, okay? I had two of these on little kids and in the same accident. They both had lower extremity blowout fractures. And how are you going to splint that?
You just put it
there.
you wrap.
You basically scoop everything up and then you try to, I don't know,
Just kind of put it
Dude.
put it in a bowl.
oh, you want to leave it behind.
So
Goodbye.
here's what you do. To sort of train for this, you can train for it at home. It might be a little pricey, but you can train for it at home. Get a pound of hamburger meat, okay, out of the wrapper. Take the pound of hamburger meat, throw it on the ground, go splat, right? So splint that. So what you do, you take and you do this, you sort of scoop it up, okay, and slide an abdominal dressing underneath it, and sort of wrap an abdominal dressing around it, and then find something to tie a splint off to, right? I mean, it's not pretty, but that's not the only way to do it. These are, who knows really if the way that they do surgery now, who knows if they lose the leg or not. My bet would be yes, but I've seen them up in the arm, blowout fracture and the humerus. Granny was checking her trailer, you know, and it backed over, horse trailer backed over her arm, and her arm almost fell off. You know, it just really sort of hanging on there so difficult to splint, but very critical fractures. All the tissue here is blown out. That's why it gets the blowout fracture. You might want to close your eye. Oh, never mind. Compared to that, this is so fractured or dislocated.
It's dislocated.
That looks
Wait,
dislocated.
the knee looks dislocated, but the
Ankle looks fractured.
no, I would
I mean,
say
there's
it's
where
not.
the problem
No,
is. It's
yeah.
just sort of,
no, the knee
that's
looks
not false
fine.
motion. You can actually turn your ankle that way.
The kneecap looks fine. It's the fact it's like the tibia and
The
the tibia
kneecap-
don't
the kneecap
look
is
like they're just.
The kneecap is definitely crooked, Charles.
Shoe off. The kneecap is almost on
It
the
looks
side.
like they're
Dislocated.
Yeah.
No, I'm sorry. Fractured.
Really?
It was fractured.
Fractured?
Yeah.
Fractured where?
Yeah, right here.
Well,
Okay.
okay.
But I didn't want to rub salt in the wound, but I was like, if you would have laced your shoes up tighter, maybe you wouldn't have fell. But no. She's a nurse now, so she's doing fine.
Yeah.
Yeah, but they were doing some hiking or something. Anyway, ow.
Oh.
Wait,
How is that helping you?
I must have been running hard.
I really like the caption.
Broken.
I'm telling you, those soccer, anybody soccer?
Wait.
They kick hard. I mean, they really kick. A lot of force goes into that. Anyway, fractured, right? In the mid bone, some false motion in there. Okay, so maybe enough of the pictures for a minute, so you can open your eyes. The complications, obviously hemorrhage, right? Tissue damage, nerve damage, infection. So we want to make sure that we're bandaging with dry sterile dressing over those open fractures, and we could have decrease in circulation as well. Okay, so there's some complications that go in. These are more long term. Hemorrhage is a short term. We'd have to control the hemorrhage. One rule of thumb, unless you just have to, that you wouldn't put a tourniquet over a bone, over a fracture. But I've had to do it before because they were just pouring out blood. So it was either put the splint, the tourniquet over the fracture by the fracture site, or let them bleed to death. You know, so the tourniquet went out. The guy actually lived, so he lost most of his blood volume in the back of the ambulance. But anyway, so there's some complications to it. All right, we would make sure that we splint and that we would control the infection by using a dry sterile dressing. A strain, okay. A lot of people say, "Oh, you know, I tore my hammy or something," but most of the time, and those are strains. So, because those muscle fibers they're all like this, right? And so if we strain, we just sort of stretches that. When we tear or pull a muscle, tear it, these fibers come apart. That's much more serious. Playing softball with the guy who tore his hammy, and he was out of work for 6 months. He was in left field. I was a shortstop, and it sounded like a gun going off. And when I turned around to go, I turned around to get the ball, right, because he's throwing it to me, and all of a sudden I heard this pop. I mean, he's in the back part of left field. Pop, I'm like, you know, and he dropped like a rock. And I was like, get the ball, man. Man up, get the ball. But it was all black and blue, and I mean, all bruised up, big, huge contusion in therapy. And like I said, he was a mailman, so I think, so he couldn't walk for 6 months or so. You know what I'm talking about? Yeah.
Good one, Randy.
Yeah. Okay.
I know exactly what you're talking about.
A sprain is just to the capsule, you know, the ligament. So we have a little sprain, or, you know, we tweak that, you know, it's sort of the common phrase. We just sort of tweak. Either one, okay? Because like we told you before, been sort of tricked on these sprains, strains, fractures, splint, right? We always splint it. So not really big change in direction for us, okay, when we look at it. Dislocations, very, very painful.
Yeah.
We walked into this one lady's house, and her shoulder, a lot of times, especially in football players, the shoulder will dislocate anterior, right? So you can't tell if it's a fractured clavicle or a dislocation. Anyway, if they're in this position here, you would just, that sling and swab, you put a sling and swab it, immobilize here. The swab, where you tie that tri-band around their waist and arm, is help to immobilize the shoulder, okay? This person had her arm out like this. It dislocated in this. She was older, and her house was like 90 degrees inside. I mean, it was like a sauna in there. And she was screaming at the top of her lungs. My partner, because of the heat, he was a little fatty at the time, but I'm telling you, because of the heat and everything else, he goes, man, I'll go get a splint. I'm like, man, I haven't really determined how we're going to splint this yet, but I'll go get it. He went out and threw up on their driveway, but we couldn't move her arm. She was just like this. She goes, it hurt way too much to even move. So, like, what's the problem? Well, yeah, I think it was her right arm actually. But, yeah, he had to sort of position her logistic wise to get her in the ambulance.
Yeah.
We couldn't move it. They didn't want to reduce it. Reducing a dislocation, there's a lot of nerves up here, okay? It's outside of our scope of practice, so I can't reduce that. Gave her some pain, so or pain medicine, so she'd stop screaming. But that was it. But be very careful with this. You would try to splint that in the position found, or at least in the position of comfort, okay? With the dislocations. It's like the knee here. There's no doubt that there's something, but we still don't know if it's fractured or dislocated, right? The gymnasts are the best, because you can take their knee and their thigh and do this with it. You know, I mean, it just sort of moves like, yeah, that's not good. But with the different tears, but again. So we'll pick it up later, but we're going to learn to splint a joint, okay? So the easiest way would be just put 2 long splint boards sort of running across there and splint that in place. We don't want it moving around. If they can straighten it out without pain, then you can just splint the leg, right? But here if they can't move it without pain, then we'd splint the joint. Okay.
What they did for me is that they used that air pump splint, and the position it was already in, it was slightly better.
Okay. So you don't want to move it around too much. Get the X-ray in there, like say, figure out I want to make sure there's not any nerve damage or whatever, okay? So all these they can present with the same signs and symptoms, but you want to always look at the mechanism of injury, make sure that, sort of evaluate that. But it really is just as easy as, hey, dislocated, sprain, strain, I'm going to put a splint on it. If you have other problems, airway problems, I can't tell you how many times I've taken patients to the emergency department with femur fractures and radius ulnar fractures and all this, unsplinted. Okay, the body makes a great splint. This femur's fractured. I'm going to tie it to this one. This other uninjured leg makes a great splint. Okay, you do that in the case where you have other problems. Maybe you have airway problems, right? You wouldn't take your time out of the airway to splint a fracture. Okay, so it just depends. If you can splint that. I've had people with radius ulnar fractured. I just sort of threw their arm across their chest and tied it on there. Actually splinted it to their chest. Had other problems, right? Other priorities. So a lot of times fractures are not the priority. However, like a femur fracture, a lot of vessels, right? I think it says here, yeah, you can use, I thought it was around 1,000, but this says 1,500, same sort of thing, 1,000 to 1,500 milliliters of blood loss in the femur fracture. All right, 3,000 in a pelvic fracture. You can lose half your blood volume with the pelvic fracture. The pelvic fractures, now, when we talk about a traction splint here in a minute, we'll talk about a different type of femur fracture, a mid-shaft femur fracture, but I mean, if you just have a regular, uncomplicated femur fracture, then you would splint the entire leg, right? But if you suspect that the pelvis is fractured, they make a different, like a pelvic binder, different things for that. There's a picture coming up. But the most severe pelvic fracture is an open book fracture. And so it's like this, right? You have a book here, like your two hands are the book, and it's open book. That means this, the ischiums are fractured, and the pubis symphysis is fractured. So this is like this. It's very easy to recognize an open book pelvic fracture. That's the one that they can lose the most blood volume in. Just because the patient will be laying there and their legs are out to the side like a baby that's about to get their diaper changed. You ever change the diaper? You know how the baby's legs sort of fall out to the side? That would be what it would look like with an open book pelvic fracture. This binder thing that they have now is great. I've used it a few times, and you just take it and Velcro it around, and you open book, you just pull that back together. Again, it takes seconds to use. Anyway, so a lot of blood loss there. Like we were saying, the only way that you can diagnose it really is to have the X-ray done to it to make sure. We just splint and transport. As always, do a good trauma assessment, right? Your DCAT BTLS, right? You're looking for that. You're looking for these different signs of a fracture. You don't remember. It's not your job, my job, to confirm the fracture. It's just to splint it and document the findings. Okay. Pain, bruising, swelling, deformity, exposed bones, we looked at all that. Tenderness, grating, that's sort of a word, like, we have bone fragments. It's like crepitus. Remember crepitus? The rice bag, you feel the bones. You take that rice bag and you run your fingers over it. That's crepitus. You have the bone fragments there, okay? It's one way. And then they give you a little hint to sort of help try to sort of like sample OPQRST, right? Pain, collar, what's that?
Oh, I don't know. I don't recognize that. Collar?
Skin distance with injury might be pale. And capillary refill is delayed.
Yeah, it's sort of like a pasty white. It's probably about this color here. If you were to look at it, sort of the grayish white color. Okay. Paralysis, we got that down. This paresthesis, is that like when your hand falls asleep and you feel that sort of tingling in there.
Yeah.
Okay. Different pressures, pulses. So these are the things that we want to sort of look out for that can help us with the assessment as far as the fracture is concerned. Okay. And this just follows your patient assessment flow chart or your patient assessment skill sheet. Maintain spinal mobilization, administer oxygen, evaluate the need for oxygen, right? Splint the joint. Once you get it splinted, a lot of times the pain will go away, will decrease the pain level. So a lot of fractures that I've dealt with, once you got it splinted and stopped the moving part of it, right? The pain went away. They could tolerate the pain. Cold packs and elevation for the swelling, even the short time that you're going to have them, this will help. Okay. Look at those vital signs. Get a good baseline set of vitals. Recheck. Reassess your CMS, right? Your pulses, motor, sensation, function. Okay. Make sure that your splint is not loosening up or moving, especially in a vacuum splint. North Texas, we don't use vacuum splints. One, they're too expensive, but two, you have a hard time sort of keeping them. How much do you pump that thing up? Is that too much, too little, right? Most everybody uses a board splint. Where were you when you put a vacuum splint?
Here.
Really?
Yeah.
Like the EMS?
Yep.
That's strange. Scratch that North Texas, but most everybody just uses board splints. Vacuum splints are really a thing of the past.
I don't know. I mean, like, I guess it's the fact of like, I couldn't really bend my leg really at all. Otherwise, like my pain on the scale would like shoot to like 8, almost 9 if I try to straighten out. So I guess my leg was just too bad in order for them to like do the board.
No, you could still board splint it, but either way, I don't know. Make sure that one thing on like when you're doing this skill, testing this skill, if you have a lot of movement, that's critical criteria. That's gonna fail you. But you don't want to have a lot of movement. You don't want that bone moving around. Okay. If your patient has a femur fracture, you really don't want to sit on the femur that's fractured. It causes the patient a lot of pain. Okay. Remember, you're in the back of a moving ambulance. I sort of moving around and lost balance and did one of these things and actually ended up on the patient's femur. And I'm like, whoops, sorry about that. I'm gonna give you some more morphine. You're gonna get all about it. But anyhow, that is a problem. But once you get it splint, it reduces the complications and the pain for sure. And these are the same sort of, we can restrict blood flow due to the splint, right? We can get our splint on too tight. We can get it too tight up in the joint where it causes a compression type of injury as well. So those are things that we have to be cautious of.
Right. So do you check the motor blood pressure and everything? Like after you put on the splint, do you just like wait a few minutes or check again with the motor pulse or?
Yeah, so I would check probably 5 to 10 minutes. I would just reassess, CMS to make sure that the splint's on good, that it's not on too tight. I wouldn't wait 15 minutes. You hook down the extremity smurfed out, you know. I check about every 5 minutes just to make sure that they can still move. It's easy to do. Okay. Keep an eye on the wound itself. And we've already went through splinting, and I'm going to flip sort of quick through here. The big thing, CMS, right? That's a critical criteria in skills testing and in life. That's a critical criteria. Immobilize the joint above and below the fracture site. Cover the wounds, okay? Splint in the position found, unless there's a compromise in circulation, if possible. Obviously use the padded side of the splint. What they mean by hold traction on a splint, like if you have a femur fracture, it's not actually pulling traction, it's just holding it in place. Okay, so stabilize the fracture site. That's part of the skill. Okay, and be leery for shock when you look at it. So evaluate the need for oxygen. This she's doing the CMS check, right? Remove the clothing away from the fracture site. Cover the open wound. I would go ahead and remove all that clothing, but so it wouldn't get in the way of my splint. Stabilize the fracture before you start to splint, and then measure your splint above and below the fracture site, and then make sure it's secure where the splint doesn't move. You've already done this, so we just need to perfect it a little bit more. And, okay, so some more different types of splints. You have the let's see, you have the air splints. I think there's pictures. Here's a picture of the traction splint, right? You have what's called a SAM splint. You've seen the SAM splints before, right? The ones you can bend back and forth. I had one in here for a while. You know what I'm talking about? Stand by.
Girl, shut up.
Little mini SAM splint. Okay.
Is that a finger?
Oh.
That's adorable.
So you could take, you have a fractured femur, or finger, sort of bend that around, okay, and then attach that. They have long ones. I have some in the closet. You can, they're very handy for radius ulnar fractures. They're a little thin for femur fractures, or legs, but they do work. Like if you need to put it in a little boot for the foot. Say you had a little foot there, you could stick in there. Okay, so they just bend around. Okay, so bend that wheel. SAM splint is a brand name. Okay, the spinal board that we're somewhat familiar with is also a splint. Splint's the body, right? We'll talk about the different types of traction splint. Fortunately, they've taken traction splints out of the testing process because there's so many different kinds of them, and not a lot of people use traction splints anymore. There's only one reason that you would use a traction splint, and that's a closed mid-shaft femur fracture where the hip and the knees are not involved. Okay, so isolated closed mid-shaft femur fracture is the only indication for a traction splint. If the hip's involved, you attach that traction splint, which we're going to do. We're going to practice with them. You'll pull the hip out of place. You pull them apart, okay? Because this part right here on the traction splint sits up underneath, what's that, the ischial tuberosity?
Oh, yeah.
Commonly known as your butt bone. It sits there. So if they have a pelvic fracture, it's going to pull them apart. So it has to be a closed mid-shaft femur fracture. They're easy to recognize because it looks like they have a basketball sitting right in the middle of femur. Not too many used anymore because you're not sure whether the hips or knees are involved, so you can just board splint it. However, the traction splint, if it is a closed mid-shaft femur fracture, once you pull the traction on it, the patient gets most of the relief. Once you get it pulled, I've never had to really use narcotics to relieve their pain. The splint itself does it, which is good for the surgeon. Anyway, there's a picture of it. We have one that we'll practice with when we get there. Like I said, a vacuum splint, sort of old school for me, but and we never really used them because they're expensive. The board splints are cheap, disposable. You try to get the vacuum splints back. The problem I have with vacuum splints is just the amount of pressure that you use. You get too much, too little, and they're time consuming. The board splint you can get on in just a couple minutes. But that's just the same splinting rules apply. You're just using a vacuum. You pump that vacuum splint up. We'll look at a pair of pneumatic anti-shock garments, or they're called masked, or what? Pneumatic masked trousers, but you have, if you're technical, they're just masked. Military anti-shock trousers is what the T. So if you call them masked trousers, you're repeating the T, trousers twice, right? That makes sense? Yeah. Or pneumatic anti-shock garments. The great state of Texas has taken this off of the testing thing now because hardly anybody uses. Way back in the day, my day, we would splint pelvic fractures with them. We splint lower extremity fractures. We treat shock with them. You'll see when we get them out, put them on. Okay. I got a pair because I dug them out of the trash can. To buy them, they're like really expensive, but nobody uses them anymore, so they were thrown away. So I was around, I'm like, hey, I'll take that, you know. But otherwise, I'd have to buy a pair that we would never use. All right, so pillow splint we already talked about. You just use an ordinary pillow. A lot of things can be used as a splint. Your notebooks, good solid notebook could use as a splint. Anything just to keep it from moving. So a pillow actually works really good. If you have a hip fracture, one sign of a hip fracture is the affected side. Let's say the patient's left hip is fractured. It's going to be shortened and rotated outward. So short and rotated outward is a sign of a hip fracture. You put a pillow in between the legs and tie the legs together. Splint it to the good leg. Okay, that's very acceptable for pelvic fractures. We would put them on a backboard just to move them, so we wouldn't have to be moving them around, but wouldn't necessarily need spinal mobilization. The backboard would just be for movement. Okay, so we talked about that, compressions of the nerves and the tissues. We get it. You don't want to delay transport at all for us to be putting on a splint. We get it too tight, we can decrease capillary refill, circulation there, and move it around too much. You make the injury worse. All right, so we'd be careful of that. Long bones, short bones, it's the splinting process is the same, so I'm just going to sort of flip through this. We'll talk about the traction splint at a later time. So we have the picture. You can have the patient hold the fracture as well. Does she not look like, what are you doing? She doesn't have the look of confidence to her face, does she? But anyway, check good CMS. sort of maintain or stabilize the fracture, put the splint, whatever kind that you're using, underneath it. They're using the air splint and pump it up. There. Check CMS again. A minimum before and after. It's a critical criteria on the skills testing. Let's make sure that we do that. That's the way most people fail a splinting skill, is they forget to do their CMS checks. That's why when we practice, you want to go down through the skill sheet, right? Okay. Joints sort of the same way. The rules apply the same. Like Chuck was saying, you get move. It hurts too much to move, so you splint it in place. Right? Good use an air splint there, but you could use a board splint the same way. I'm not sure where these are made, but they like air splints. But put a board splint on either side just to keep that joint from moving around. Okay, works well. I'll show you how to do that with the board splint. CMS checks, right? Same complications takes place with any kind of splint. And then when we look at traction splinting, we'll wait till we can get it out there and look at it. We'll walk through traction splinting with the splint itself, okay? And this is just saying, this is important, to make sure that, it's not an injury to the distal proximal femur, as well the pelvis. So there's a lot of sort of contraindications for a traction splint, because there's only one indication, a closed midshaft femur fracture. And then there's the pneumatic, which is air, anti-shock garment. When these first came out, they were used for shock. They were used to treat shock. They did quite well, but that big do not cut that's all over them, the ED staff would still cut them. So it's the pneumatic anti-shock garment's like a big, huge air splint, and you cut it, and all of a sudden, all the pressure and everything goes away instantly. So the patient's blood pressure would drop instantly, and we changed the way we sort of look at blood pressure and shock. Back then, when we were using that, we wanted to get them up 120 or so. Now we want to leave them, lower pressure, somewhat. This is the pelvic girdle that we were talking about. It just sort of wraps around. If you were to look at one, have you seen those fat belts people wear around their waist? You can probably find 1,000 of them now. That's January. Everybody in the world wants to get in shape, right? That'll last a couple of weeks. And so they just wrap this around, and like I was saying before, it pulls that pelvis together. They do work well. Relieves a lot of pain for the patient. Look for those on the ambulance when you go do your rod outs. Say, hey, where's that pelvic thing at? That pelvic binder. They'll show it to you. Hopefully you get to use one, right? Wouldn't that be cool to get somebody all jacked up and have an open book pelvic fracture and all that? You can only hope. Huh? Yeah. Trauma is going to happen. You might as well be around. Right? I mean, it's going to happen. You might as well be there. The way I look at it. Huh? Oh, yeah. They'll be inviting you back. Hey, why don't you come back next shift?
We went to the hospital, out of the whole, the ER, and then, the fast track and triage, all that, one patient. And she was so asleep, I thought she was unconscious for a while.
Well, yeah. Well, white clouds. You can develop some pressure in the joint compartment syndrome that you have to be Then if that started bothering the patient too much, you can loosen that splint, try to loosen that, but it'll go away typically when they remove the splint. Pain, burning sensation, can't really move the extremity, okay? But you could still have good CMS with it. And then lastly, the pathological fracture, where you, like we talked about, you have that diseased bone, okay, that just fractures. It's really no other treatment. The treatment is not different at all. You would still splint it, just like any other fracture. Okay. Cancer caused that. I forget the name of a lot of them. Okay. Easy enough. Questions? Very good? Okay.